Good afternoon, all. I am Dr. Murtaza, presently working with Ramesh Hospitals, Vijayawada. Today, I will be presenting a paper on role of tissue Doppler and strain imaging in the assessment of ventricular dysfunction in multi-transfused thalassemic children with iron overload. Thalassemia major is a disorder of hemoglobin chain synthesis, and these children are subjected to multiple time blood transfusions. It has been seen that the iron absorption in these children is much more than those in the general population, and up to 0.5 milligram per kg per day iron is absorbed in these cases. So the deposition of iron in their different tissues can be there, which includes heart, liver, gonads, pancreas, and other systems. The iron-mediated dysfunction can produce in the form of myocardial failure, endothelial dysfunction, arrhythmias, pulmonary hypertension, vascular stiffness, thrombosis, or myocyte scarring. And it is not that only it is iron-mediated, it can be non-iron-mediated also. It has been seen that aggressive chelation, it prevents and delays, but even reverts this iron deposition. So early recognition can lead to disease modification, but early recognition is difficult as global ventricular dysfunction and exercise capacity remains normal until late in the disease process. 2D echocardiography, subtle cardiac dysfunction is not picked up. Tissue Doppler imaging and strain imaging are superior for regional and longitudinal myocardial dysfunction, but many studies are showing varying results in these cases. So our study was an analytical cross-sectional study in which 33 thalassemia major children of the age group of 2 to 18 years were included in the study. Age and sex matched healthy controls were taken, which were 32 in number. The study was done over a duration of 15 months, and all children who were of thalassemia major who were iron loaded, that is, they had a ferritin of more than 1000 nanogram per deciliter, were included in the study. Baseline parameters and detailed clinical examination was done, and echocardiographic assessment was done with conventional 2D echo, tissue Doppler imaging, strain imaging, and strain rate imaging with Philips IE33 machine by an operator who was blinded to the clinical data in lateral and supine position with S51 transducer with ECG gating, and 3 beats were digitally stored for offline analysis by QLab version 8.1. In the baseline parameters, it was seen that the weight, BMI, diastolic blood pressure, ferritin, and hemoglobin were significantly different in the two groups. Out of the 33 children, 50% of them were on multiple chelation therapy, which included deferoxamine, deferriprone, and desferoxamine. Moving on to the 2D echocardiographic parameters, it was found that left ventricular end diastolic diameter, left ventricular end diastolic volume, interventricular septum end diastole, and LV mass were significantly higher in the thalassemic group in comparison to the control group. In the tissue Doppler imaging parameters, which were done on the lateral LV wall and septal LV wall, it was seen that the SM, EM, and AM were significantly lower in the thalassemics in the lateral wall in comparison to the controls, whereas there was no significant difference in these 3 parameters when it was assessed on the septal wall. In the strain and strain rate imaging parameters, which were done in the LV basal mid, septal basal mid, and RV basal mid, it was seen that these children of thalassemia major had strain parameters and strain rate parameters which were significantly lower in the thalassemics in comparison to the controls. So in the 2D echo parameters, we found that left ventricular end diastolic volume, left ventricular end diastolic diameter were higher in the thalassemics along with the LV mass, whereas the left ventricular ejection fraction was more or less comparable in the two groups. Myocardial performance index was same in the two groups and there was no significant difference. So ejection fraction and mitral inflow velocities were similar in the two groups in the echocardiographic 2D parameters. when they were assessed with tissue Doppler imaging parameters, it was seen that velocities at the septal LV were comparable between the two groups, but velocities at the lateral LV were lower than the controls. So, despite a comparable left ventricular ejection fraction, there was differential abnormality which existed in the tissue Doppler imaging parameter. In the strain imaging parameters, it was seen that both the strain rate and strain rate imaging were significantly lower in the thalassemics in comparison to the controls in all the measured segments. As like any other study, this study also had limitations. It was a single central study and there were limited number of patients included. It was a single point study, cross-sectional. Had it been a serial study, which are needed in future, it is needed to clarify if changes in strain imaging and tissue Doppler progresses to ventricular dysfunction if they are done follow. Analysis of each patient by more than one observer will improve the study. And MRI T2 star is the gold standard, but we have not compared ours with those. So concluding my talk with ventricular dysfunction is common, but it increases with age in these thalassemic children. And the important point to note here is that chelation reverts it. Ejection fraction by 2D echo and global ventricular function remains normal till late. Tissue Doppler imaging and strain imaging picks early and regional myocardial involvement. And these two parameters are superior to conventional 2D echo. They are non-invasive, less time consuming, easily available, less costly, and good for resource limited settings. Thank you.
Thank you, Dr. Murtaza. That was well and